All right. Welcome everyone to our online webinar and good afternoon. My name is Catherine Sorsdahl and I am the co-director of the Ellen J. Fletcher Center for Public Mental Health in the Department of Psychiatry and Mental Health here at the University of Cape Town. On behalf of the Center and the African Mental Health Research Initiative Amari, I'd like to welcome you to this webinar on the mental health aspects of the COVID-19 crisis here in Africa. There's clearly a lot of interest in this topic, and thank you everyone for making the time. We're still waiting for a few people, but we had over 200 registrations today. So while mental health is not always viewed as a priority in our settings, in the current pandemic, it's become impossible to ignore mental health. And we are very fortunate today to have 4 panelists with vast experience that coincide with the 3 major mental health care aspects of COVID-19. So the first mental health aspect of COVID-19 the availability and provision of psychological and psychosocial guidance and support on how to cope with stress for the general population. And today we have Professor Chiroza Bandawe, a clinical psychologist from the College of Medicine at the University of Malawi, to discuss this aspect. This aspect also includes specific subgroups and information for these subgroups, including children, adolescents, the elderly, and people living with disabilities, whether it be physical, intellectual, and psychosocial. So importantly amongst the subgroups are mothers. So today we have Professor Simone Honigman, the director of the Perinatal Mental Health Project, here to discuss mental health responses to COVID-19 for mothers in South Africa. The second mental health aspect of COVID-19 is the availability and provision of psychological and psychosocial guidance and support for those who are directly affected by the virus. And this includes healthcare providers. So to discuss this aspect, we have Dixon Chabanda, a professor at the Center for Global Mental Health and the director of Amari based in Zimbabwe with us today. Finally, the third mental health aspect of COVID-19 is the availability and provision of essential mental health services for those living with a mental illness in generally. So I know that there's been a lot of discussions about this in our department, and today we have Professor Jose Luis Ayoso Mateus, Chairman of the Department of Psychiatry and Director of the WHO Collaborating Center for Mental Health Services Research and Training at the Universidad Autónoma de Madrid, who will be speaking to us about lessons learned on this key aspect from Spain, who, as you know, is ahead of us in this pandemic. Just in terms of logistics, Chiroza is going to start, followed by Dixon, Jose Luis, and then finally Simone. And each panelist will have 15 minutes, and then we'll have 15 minutes for questions. So you'll see a chat function on the right-hand side of your screen. So please do put your questions in those boxes. Dr. Claire van der Westhuizen, who is a medical doctor and former Amari Fellow, who is now a senior lecturer in our center, is going to be facilitating this discussion, including the webinar today. So let me hand over to Chiroza in the meantime, and thank you very much for coming. Hi, Simone. Sorry about that. There's been a bit of a glitch on getting Chiroza online, and then Mahi's computer froze. So if you guys can hear me now, is that all right?
I can hear you.
Yes. So what we're going to do, Dixon, is we're still going to try to get Chiroza online, but in the meantime, let's start with you,
Sure.
and then we'll Louis and then Simone. Sorry about that. And let's get going.
All right, so let me see. Where do I go for sharing? There we are.
Yeah.
Let's see what happens. Oh gosh, I've got like a million things here showing up all at once. So how do I?
Just need to open up your presentation and make it full screen, and it should be all right.
I have opened it up.
Yeah.
Let me try once more, because it is full screen.
Okay. There we go. Yeah.
Can you see it?
Yeah, that's perfect.
What does it say?
Psychological and psychosocial support during COVID-19.
Great. So shall I start? I mean, it won't be a long presentation.
Great.
Thank you very much. Firstly, thank you, Catherine and team for organizing this webinar. I think it's really important for us to be getting together and sharing how best we can deal with the challenges, surrounding all of us related to COVID. The past couple of weeks, I've had a number of people contact me asking, how best can we help We want to do something. How do we reach out to those who are in need? What do I do when someone gets in touch with me? You know, if a neighbor has been in touch with me, you know, so it's like, how do we talk to those who are affected? What techniques do we need to use as we interact with people who are affected? Do I need to be trained? You know, the list is endless of the different things that people are requesting for. And obviously in 15 minutes, it's not possible to train anyone to provide any kind of meaningful intervention for those affected by COVID. But what we could probably do is highlight some of the do's and don'ts in relation to the kind of psychological and psychosocial support that we can provide to those who are affected. When you think of the different care platforms that we could make available for those affected by COVID in different ways, one way of visualizing the care platform is through a pyramid. If you think of a pyramid or this triangle here with the base representing pretty much the bulk or the majority of people who will need care during this period. And as you go up the pyramid, it becomes less in terms of the numbers of people that require services. When you think of the platforms of care that are out there that we could probably tap into, self-care is one which is pretty obvious, you know, empowering people with, you know, basic skills through psychoeducation and awareness programs. And as you go up the pyramid, as you can see, it becomes a lot more complex in terms of requiring professional input. The first rule of thumb that I would like to really share with you when we think of providing care at this level is that you don't have to be a specialist. There's overwhelming data and research which shows that ordinary people within communities can actually contribute significantly towards narrowing the treatment gap for, you know, mental, neurological, and substance use disorders, you know, by simply getting very basic training, you know, and it's in line with the concept, the global mental health concept of really narrowing the treatment gap. There's a recent publication which actually shows some evidence to that effect. You know, this was an umbrella review which looked at the efficacy of psychosocial interventions for mental health outcomes in low and middle income countries. And essentially what the authors concluded was that interventions delivered by providers who are not mental health professionals actually do work. And there are several other publications that are out there. So in essence, that's what I would really like to briefly focus on, is on how can we empower ordinary people? How can we empower ourselves in the face of this crisis so that we can be seen to be contributing to addressing psychological and psychosocial needs of those who are affected. A month or two ago, I had a friend of mine who recommended I read a book, which was an autobiography published by an author that I had never heard of. The name is Albert Woodfox. And this was an autobiography of a man who essentially had spent 40 years in solitary confinement in a prison in Louisiana in the USA. And it's really about his story, a story of being in solitary confinement. It's his story of being unbroken by 4 decades of solitary confinement, a story of transformation and hope. Although this story kind of highlights the injustices within the legal system in the United States, what we really learn from this story is resilience, what it means to be resilient in the face of adversity. This story is about how to ensure that you have structure when you are faced with difficult times, how to grow in an environment where your freedom, what you seem to take for granted, is suddenly taken away from you. And above all, it's about humility and compassion and how that drives and creates a sense of purpose. There are many global icons who have gone through this similar path. When you think of the likes of Nelson Mandela, Mahatma Gandhi, Mother Teresa. And so what I really am hoping is to share some lessons from some of the global icons. Now, obviously, Nelson Mandela, Mahatma Gandhi, Mother Teresa, these people are no longer with us. And I thought, why don't we look at what's really happening right now? Who are the global leaders that we can learn one or two things from in terms of how to reach out to people, how to provide support to those who are psychologically affected by the COVID-19 outbreak? And then one global leader that seems to stick out when you look at the consistency of producing results is the Prime Minister of New Zealand, Jacinda Ardern, all talking about flattening the curve, and they've done some great work in New Zealand, not only with regards to COVID, but with regards to a lot of other issues. If you recall, last year in New Zealand, they had the Christchurch massacre where a lot of Muslims were killed, and her response to that was phenomenal. If there's time, we can get into that in details. But the one thing that strikes me about her style of leadership, because a lot is being spoken out there about leadership. The one thing that strikes me about the Prime Minister of New Zealand is that she has mastered the art of using empathy as a tool to reach out to people who are in need. What exactly is empathy? Empathy is really, in very simple words, the ability to make people feel understood and respected. And she has been phenomenal when it comes to doing that. If you follow the way she has managed the COVID containment in New Zealand, or if you look at previous events that have occurred in New Zealand, they've all been rooted in this strong ability to make people feel understood and respected. And that's the second most important thing if we're going to be speaking and reaching out to people out there. We want to create what we call in mental health or in psychology a therapeutic alliance. And creating a therapeutic alliance, in essence, is really nothing more than giving people space to tell their story. When you look at the way Jacinda Ardern responded, for instance, to the Christchurch massacre or attack, it was one response which was full of empathy, where she connected with the Muslim community. But it wasn't just about connecting with the Muslim community, but she gave them space to tell their story. And by doing that, she really created this community cohesion. Of course, one will ask, how exactly do you create that space? It's again, it's not rocket science. It's really based on listening. Are we giving people the opportunity to tell their story, and are we listening? And when we listen and acknowledge in a non-judgmental way, we are providing space for people to actually begin to realize their own true potential to heal. And you don't really need much training to do that. Of course, there's listening, but there's also what we call empathic listening. And when we listen with empathy, what in essence we do is we create the moment where we are linked with the people that we're trying to help. You are in the present moment in the activity or the action that you are carrying out. And when you look at some of the great leaders, if you've ever observed any of the videos of Nelson Mandela speaking, he was an amazing not only an amazing orator, but he was really great at empathic listening. The same goes with the likes of Mahatma Gandhi or Mother Teresa. And these are skills that you don't really need to acquire by going to a psychology course or by becoming a clinical psychologist or psychiatrist. These are things that we can all kind of be a little bit more conscious of when we communicate with people. And of course, another important thing as you communicate with people who reach out to you, is naturally you will ask questions. And when you observe great leaders, they focus a lot on open-ended questions, where as opposed to saying, why didn't you do this or do that? One would say, would you like to tell me more? And then, of course, there's the feedback that is an anchor in terms of your ability to actually interact with the people that you're talking to. And by feedback, really, in essence, it's really about being able to summarize what you hear over the phone. Somebody's reached out to you and you're trying to give them some support or some kind of help. How do you summarize what you hear? Because the summary is really the true indication that you are rooted in the present and you've been listening. You've acknowledged in a non-judgmental way by providing a summary of what you heard, which reinforces the notion that you've understood and you've respected the person. Having said all of that, when we provide support, it's also important to understand that people will be at different levels of need. Again, I've used something that you're probably all familiar with, Maslow's hierarchy of needs. I'm into triangles today, I've just realized. But this is really something that is old, in terms of understanding human needs, and it's an oversimplified visual illustration of needs. But as you talk to people, some people will have psychological needs. Some people will have safety needs. A month ago, I was in the UK, and while I was there, when the lockdown was starting, there were reports of a lot of people who were, subjected to abuse in the home, intimate partner violence and all those kind of things. And people reach out, then you're talking to them and you realize that there's a safety issue here involved. So there are many different issues that may arise. And so it also becomes important to be aware of what you can provide and what you can't. For instance, you may need to refer people further to get extra help or support, depending on what it is or what the story it is that they are sharing with you. And when you bring all of that together, I've borrowed this slide from the Friendship Bench, where we use what we call the Friendship Bench card, which is really a summary of bringing together all the things that I've just talked about. You listen in an empathic way and you list what you hear. You provide a summary, and together over the phone or through WhatsApp, whatever chat platform you're using, you explore the possible solutions, together with the person you're talking to. It's just one simple step at a time, being clear of when you should be referring. But the key thing when we provide support is really to be there, to be rooted in the present and to listen. And of course, we can spend a lot of time just discussing the Friendship Bench card and how it works, but I'm not going to do that, as I'm just really kind of going through the basics of how we can reach out to people. And of course, we can't not mention self-care. I love this picture here of the Ugandan president, Yoweri Museveni, who is 75 years, and he released this indoor workout video to keep the citizens at home. While we may disagree with a lot of the things that Mzee is doing in Uganda. But I think this is a great example from an African leader who is, showing people the importance of self-care, the importance of being able to exercise within your home, within this this crisis as we are all under lockdown. And so I would like to just conclude by looking at how we prepare for life after COVID-19, because in a lot of ways, the world as we know it today will not be the same after this is over. And we all have different ways of trying to prepare for that, or trying to understand what is happening, whether you are providing care to somebody or whether you are providing care for yourself as an individual. These are important questions we need to be asking ourselves. I've flagged one particular book here, which I read recently, which I think is a great book, which really highlights a lot of the challenges that humanity is facing. And it's something that I would definitely recommend if you want a good read, something that will help you to be rooted in a very clear fashion in terms of what is happening, how we can help ourselves, and how we can help those that need to that need help. And obviously, it's all about maintaining clarity. Maintaining clarity has become really critical as we try to deal with COVID. So I will stop there. Thank you very much, and I will take any questions later on. Thanks.
Thank you so much, Dixon. That was excellent. We're not going to do questions in between. We're going to do them at the end, and we're going to try to get Chiwoza next online. So I'll pass you to Maki, and hopefully we can do this. And thank you for your patience, everyone. It seems like we have over 200 people, which may be taking the system more than we anticipated. So that could be it. Thanks. Welcome.
Hi.
Hi, Jose. How are you?
You want me to introduce my team, or?
Yes, please. Handing over to you. Thanks very much.
Okay. Thank you very much. Thank you for the invitation to take part in this webinar, and hello to many of you that have been connected in Nigeria, South Africa, and many other countries. Regards from Madrid. You are going to put the slide, yes?
Yeah, yes? It looks like it's coming on now.
Okay, yes. So which are this is the third one. If you can move to the first one, please. So I'm going to, as was mentioned before, we are in the middle, in Madrid in particular, in the middle of the pandemic, with a very high number of cases, and also a very high mortality, around 10–12% of those diagnoses. And I'm going to focus my presentations on what are the challenges, what are the decisions that we made, and what are the recommendations that I can make from our experience, from my personal experience in managing all the provision of mental health services under these circumstances for an area of Madrid. In Spain, and in particular in Madrid, we have a highly developed mental health public service. And I'm going to tell you what are the challenges that we experience here, because I do think that, and I know that the mental health services and the provisions of mental health here varies around the globe, and I know it has peculiarities for some of the countries that the audience is connecting. Nevertheless, I do think that there are things that are our experience here, and the problems that we encounter could be, I think, of a good precedent, and something that I would like you to point out that may happen in any other city or country that is in a situation like the one we are now. You can move to this next slide. As mentioned before, there are many things relevant for mental health, and I'm going to focus my presentation only on the impact on mental health patients and on the impact of mental health services and how we had to cope to address these challenges that we have. There are another very important question which I'm not going to address, which is on the psychological impact of confinement and quarantine, and also on the impact on the healthcare workers, which are main issues that should be also the focus of anyone trying to plan how to respond from the mental health field. But I'm just going to focus on the impact of mental health patients and mental health services. So this is the slide which I think is the most important of the ones I'm going to show you today. Which are the clinical challenges that were imposed on the mental health services as a result of the outbreak? I mean, the declaration of the emergency state was done the 14th of March. So now we are just 1 month that everyone has been on quarantine at home, and that only essential workers are entitled to get out of their place and keep their normal busy lives. Among them, of course, health professionals and some social service sector professionals also, and also the tobacco shops and also the food shops, so that they also drink sell alcohol. So as you can see, health services are open, and also some of the things that are not so healthy are still going on because the government felt that it was necessary to keep that open. So what are the challenges that we found? First of all, that's something that happens almost immediately, because suddenly, if there's a peak of the cases, no matter how developed is the health system, how the number of beds that you have on site, the number of intensive care unit, if you happen to have a peak of cases where suddenly a lot of cases present on the emergency room of all the hospitals, of the public hospital of the city, with severe cases that need hospitalizations, and some of them need to be admitted in the intensive care unit, then most probably the decision will be made, as happened in the other hospitals in Madrid and the other hospital in Spain, that those services that were not on the front line of care of patients with COVID, with infectious diseases or cardiovascular complications or cerebrovascular complications, then these wards will be assigned to COVID wards. So that means that my inpatient unit ward with 24 patients, suddenly I receive a call on a Saturday morning telling me, you know, you need to vacate your ward from inpatients, psychiatric inpatients, because we need that for tomorrow, that we need to put patients with severe respiratory infection there. So we will, you need to arrange for a transfer of all your patients today. So that's a challenge, and later I will tell you how we cope with that. Then there's another challenge, which is very important, because most of the patients are not as not inpatients. Most of them, we see them on an outpatient basis, or they attend day hospitals, or they attend assisted living arrangements, or they attend protective employment, or they work in a normal facility. Well, there's a limitation of accessibility, because I mean, essential movements to go to health services it's legal. I mean, people will not be detained for going out of work to go to visit a psychiatrist, a psychologist, or a social worker. But there's a general rule to keep all movements outside your home at the limit, at the minimum, only the essential movements, and that includes the visits to the health facilities for what can be considered non-essential. And also the same for the workers, the mental health workers and the health workers. They also they are being considered essential, but they should try to limit the interaction that they have with the patients for two things. One is, first rule number one, avoiding them, the patients, to be exposed to health workers that may be infected with the COVID. And just a reminder of the total of cases in Spain with COVID, 19% were health personnel. So the rate and the prevalence of the COVID infection among workers of different sectors, and that includes mental health staff, and at some point, like 25% of the staff at my community mental health workers and the inpatient unit were infected. I mean, I'm talking about psychiatrists, psychiatric nurses, psychologists, and that's something that we need to be concerned about our patients. If they come to visit us, to our facilities, they may get infection. And then also the other direction, that if they come to a day hospital, they interact with other patients, they may infect the other patients. So there was a limitations on accessibility of our patients to the services that we normally provide on an outpatient basis. And then, of course, the impact of confinement on mental health patients. I mean, there's a lot of that has been said about, particularly in the general press, on the TV, on the radio, of the prolonged confinement. What is the impact on the general population? What's the impact on the children, on the adolescents? But we know there's vulnerable patients, which are the mental health patients. Having a bipolar disorder patient, even when stable, for 4 weeks without getting out of this place, that is a challenge. Having an adolescent with an intellectual disability at home for 4 weeks without going out, with a constant interaction with his relatives and his family, that also plays challenges. The same for patients with addictions. Some of them are on methadone maintenance programs, and the accessibility is still there, but it's not easy. So these has major challenges for us and for the patients, and also the support network that they have. Which is the next point. I mean, the impact on the patient support network. In Spain, as in many other countries in Africa that I know and I'm familiar, the main support system of the patient with a mental disorder is the immediate family. They are the main providers of a lot of things. And you have to remember that some of them under the current circumstances, they may all people at risk of the infection or already infected and in the hospital or die because of the infection. We have a very high rate of mortality, particularly on the oldest population, and that has an impact on this immediate support network that we as mental health professionals, we rely a lot for them to be there to implement some of our interventions, like compliance for medication, for example. And then the challenge to ensure continuity of care. I mean that the services are still there, but they are functioning at that minimum. First of all, some of the professionals are sick, so they are not there. Second, we try to avoid a lot of movements of the professionals, so that we keep the minimum staff that need to be there on site, and try to have as many of the interventions done remotely by phone or video conference from the house of the professional. So that means, in a way, availability of immediate access to the professionals when they are needed. And then the continuity of care among the different services. Some of them are non-existent. Like, I mean, we had to close the day hospital, for example. And then there's another challenge, which is a clinical challenge. And then suddenly I mean, you may hear that for months, for at least in Spain, they would say that this COVID was just like a normal flu. Oh, well, that's not true. That's not true. It's not a normal flu. It has a huge. I mean, we see a lot of very severe patients with compromised respiratory system, but also with neuropsychiatric syndromes. So very frequent the appearance of deliriums, confusional states, even in younger populations, in younger cases. Also, patients presenting with ischemic hair disease and also ischemic brain disease. So these is some things that don't happen in a normal flu, and that has been described by our Chinese colleagues, and we are seeing that on an everyday basis. And also on the treatment of the COVID infection, they are using treatments that have been tested in the past that we know that have interactions with the drug that we normally use for the treatment of confusional states, for depression, or for anxiety. And these pose challenges on the way to manage the agitation, the way to manage insomnia, the way to manage anxiety. Also, you have to remember that the patients need to be isolated. They cannot be visited by their relatives, and that's also we know that increase the morbidity and the neuropsychiatric morbidity in some of the patients, and also limits the management strategies that we normally use for patients in confusional states. We try to keep them accompanied by a relative in normal circumstances. That's out of the question here. And then we have a reduction on the personnel, or the mental health personnel, because of some of them are infected, but also some of them are moved away from the mental health services because they are needed on wards on services that attend COVID patients, because they are understaffed. I mean, the amount of people that need to be working there is very high, and that's why some of our nurses, some of our junior doctors were moved away from mental health, and they have to work on the emergency unit or the medical wards. And then, of course, the impact, the psychological impact that all this has on the mental health staff. If you can move to the next slide, please. So what are the main actions that we took? I try, and other heads of departments in Madrid try to make as much as possible mental health staff essential. You know, it's true that they close the inpatient unit, but it doesn't mean that we don't have a role still in these circumstances, because most of the interventions are being done outside in community mental health centers that are also hierarchically dependent on us. And also we do a lot of interventions as part of our normal activities that we need to keep doing under these particular circumstances. We need, of course, to improve the staff protection, because, and for that we need to train our staff and to train our equipment. Unfortunately, by the time I realized how important this was, already 25% of my staff were already infected. So it was first recommendations to all of you that are listening: start training your staff, because this will happen, this will arrive, and I mean, we know that on the mental health wards, on the mental health community mental health, there's a lot of interactions. There's a lot of person-to-person contact. We normally are not being trained how to deal with highly infectious cases, and that needs to be done both on the inpatient unit but also on the outpatient units. What I did, and the other hospitals in Madrid and in Spain are doing, we are reinforcing the consultation liaison psychiatry. I moved the staff working on the inpatient unit to do the consultation liaison psychiatry, and we expand the programs because we need to attend not only the referred cases but also their relatives. There are people that are isolated in the rooms, the relatives cannot visit them. There's a lot of anxiety, a lot of anticipated grief. Some of them died, and the relatives cannot see the body of the relatives, and all this, of course, creates a lot of psychological impact, not only on the patients but also on the survivors. And this needs to be dealt, and for that where we have a team of psychiatrists and clinical psychologists and nurses that are being very proactive on this. We need to reinforce and expand the emergency psychiatry coverage, because even on the first day of the lockdown, we saw a reduction on the need on the attendance on the emergency psychiatry. Then now, 3 weeks later, 4 weeks later, we are seeing more. And the situations are much more complicated, much more difficult to deal, because we have to limit the use of the inpatient unit, but also the normal resources that we have in order to manage the patients in the community, they are not there. So we have a lot of challenges for that. We had to move to a model of care based on telemedicine from care centers and from the home of the mental health professional. That's very important. And in Spain, we were not very familiar, and there was a lot of resistance to use telemedicine. But this is here. This is the yeah. I mean, you need to do it, and then for that, of course, you need to prepare. You need to have systems in place on your equipment. You need to be available. You need to have phone lines in the hospitals and things like that. Then another very important thing that we did was identify in advance and did a proactive follow-up of those identified as a vulnerable patients that are living alone, that we know that will have more difficulties having a quarantine by themselves, or patients that live with a frail parent, so both parents, and that we know that may have challenges for both of them, for the parents and also for the patients. Or those patients with intellectual disabilities, we know they are more vulnerable under these circumstances. Another thing that was very useful here, and I think that should be able, with the proper technology, to be implemented other places, is to ensure remote access to the electronic clinical records, because sometimes we need to do interventions far away from my offices, far away from our hospitals, network system, and we need to check how is the patient. We need to check the past history of the patient or the clinical records. And if you can get permission to ensure remote access through a VPN connection, that's extremely useful, and this was implemented here. Home assessments, we still do. We have a team to go visit the patients, and we need to give them medications or long-acting antipsychotic treatments, or blood levels for lithium, control for clofepine, valproic, all these things. We still do. We try to avoid them to come to the hospital, and we go with the necessary measures to go to their home, and with a nurse and a doctor, and we do the interventions that are necessary. And that is very important for the more severe and the ones that need a close follow-up. And then another thing, I don't know if it will be possible in some of your countries, but that's extremely useful, is that once we have access to our electronic clinical records, we also have access to the prescription directly on the electronic clinical record of the patients, and the patients don't need to come to visit us to get the prescription. They go to the pharmacy, which is close to the place, pick up the drug or the treatment that you prescribe, and that really makes things very, very easy and make us able to manage very complex cases. And then, of course, we have to implement programs to support the mental health staff. And the last slide, please. Yes, the main lesson learned, there are things that I already mentioned. The need for infectious disease preparedness. Also, very important thing, centralized decision-making and resource allocation. One of the most useful things that happened in Madrid, as soon as the emergency state was declared, the local government announced that all the beds available in private hospitals, they are now under the cover temporarily and under the management of the public health sector. That means that when they order me to vacate my ward from the inpatients, they also tell me, and then you can transfer them to any private clinic that they designated. without cost for the patients and without cost for anyone. And that was something that I don't need to negotiate nor ask for a favor. It was done. I just ordered the ambulances and the patients were transferred. And that's very important. That can only be made if there's a central decision making, because if not, I mean, you cannot waste time with these things. And the same to manage the mental health staff, because some of them will get sick and you need to relocate tasks and functions. And then you have to prioritize the protection of patients and staff. You need to do short-term planning, but you need to also think on the long term and the medium term. And we know that there will be an increase on the needs for mental health services as an impact of this pandemic, which has been described in the past, but also the mass we are seeing this has not been seen in the past. So I anticipate that this will have a strong impact on the mental health and some of the things that we are going to see, and then we need to be prepared and our staff need to be there. And then, of course, the urgent need to scale up telemedicine and mental health care. So these the thing that I just wanted to tell you. That's, you can move the last slide, please. Yes, the last one, you know, if you want to contact me, you have my email there. And it was a pleasure again to take part in this seminar. Thank you very much for your attention. Okay.
Thank you so much. I think that's a really great presentation, and it's really touched on many of the things that we're battling with many of the African countries. So I really appreciate your presentation. We're going to move quickly to Chiwoza, who's going to give a shorter presentation. So Mahi, if we could put Chiwoza on, and I know we do have his presentation now. And finally, we'll end with Simone Honigman. We are going to have to reduce our questions, or we may have to collate the questions and send an email to everyone just to get through. So we really appreciate your patience here. Thanks.
Hello, so hi, can you hear me? Do I go ahead?
Thank you. You can go ahead. I'll be sharing your presentation shortly.
Okay.
It's uploading.
Oh, okay. All right. So what I'll do is, you can still hear me, yeah?
Yes, we can.
Okay. Let me begin. Let me begin by, first of all, talking just briefly about what I'm going to focus on. We cope with anxiety and stress, particularly in these unprecedented times. From the two speakers is how unprecedented this is. The world is going down. And so fear and anxiety obviously are overwhelming and can, you know, cause strong emotions in everybody, basically. And with the
Everyone, I think the Prof is having some connection issues. I'm inviting Prof. Catherine back onto the stage, and we might have to go over to Prof. Simone.
Thanks, Mahi. Yeah, I think that's the best thing to do. Let's move to Simone. And what we can do is we can videotape or tape record Chiwoza's presentation, and we can put it online. I think that's probably the best way to move forward.
Yeah.
So thank you. And to Simone, thank you very much to moving to Simone Honigman from the Perinatal Mental Health Project.
Hello, can you hear me?
Yes, we can hear you perfectly.
Okay, sorry, it takes a while for all these buttons to be clicked. I will try and share my presentation. Machi, under sharing an app window, correct? Or share media?
A map window.
Authorizing. Share an app window or share a media?
Window media is not PowerPoint is not an allowed media form.
All right. It's asking me for authorizations and all sorts of things. So Machi, perhaps you should just share my presentation, please. Machi, are you able to share my presentation?
Just getting onto it. Hang on for a second.
Okay. Unfortunately, the test did work. Okay, thank you. Hello, everybody. Sorry for the technical problems. It's a pleasure to be here. My presentation is different from the others. I'm sharing with you the experience from the last couple of weeks where we have developed a campaign specifically for mothers in response to COVID-19. That is a messaging-focused campaign. Next slide. I'm going to have to go through this quite quickly, Machi. Can you press the next slide? Thanks. And keep going. We have found that the current messaging in South Africa for the public on health issues around COVID have addressed a very generic audience, and a generic public sector audience. There's been a focus on physical health and very little on mental health. Even though the National Department of Health has various mobile messaging or digital messaging opportunities, these have applied the same criteria. They're for a generic audience without a disaggregation of certain subsamples of the population and with an almost exclusive focus on physical health. It does seem, however, that there has been quite a substantial reach with these mobile media platforms, and in parallel with this, the NGOs in South Africa and even some of the mental health NGOs that many of us work with have been putting out some messages on mental health and on other COVID-related social challenges that the community is facing. Radio and TV are also media channels we know well that have been focusing most exclusively in terms of messaging on physical health issues and on prevention and precaution issues. Next slide. So this is just to show you briefly what the WhatsApp, the free WhatsApp line looks like. On your phone, you'd be able to see what the current COVID contact line looks like from the National Department of Health. In the last couple of weeks, this has been expanded to include new items and new menu items. But this has been extensively rolled out and used by large swathes of the population who have access to smartphones. And in the last week, has been translated into four languages in addition to English. This platform has been designed by ProCult, which is an organization, a not-for-profit organization that works closely with NDOH on providing health messages. And interestingly, if you just click, interestingly, the WHO has taken up the same WhatsApp line and the same platform and the same they say from PrayCult, and is looking to expand their offerings on WhatsApp as well. There is a number where one can access that if you're interested. We will quickly skip through the next couple of slides. This is what the National Department of Health website looks like. And on the landing page, these are the sorts of things that you can access, mainly physical stuff on symptoms, on how to prevent COVID infection, rates of infection and deaths, and interesting notifications from senior public health figures or senior governmental people in leadership positions. Next slide, keep going. So what about mothers and children in the time of Corona? In terms of infection and in terms of pathology from Corona, the virus itself, mothers and children are in fact a low-risk group. However, they represent a high risk in terms of social adversity and mental health challenges. The additional mental health risks related to COVID itself are confirmed because of the economic hardship that many mothers and their children are now facing in the lockdown period, the overcrowding that is in many impoverished homes, often paradoxically associated with social isolation, and this all leads quite profoundly to an increased exposure to domestic violence. And we know from research conducted in many low and middle income countries, in particular our own, that a significant proportion of violence in the home occurs not only at the hands of intimate partners, but at the hands of other people, other family members or people residing in the home. So we have this conglomeration of factors, social factors, that render mothers and their children at much higher risk for mental health problems and social adversity. And we know how these are intimately associated in a vicious cycle. Combined with this, it appears from our networks that with a lack of targeted messages for mothers, a lack of targeted information on breastfeeding, on immunization, on access to clinics, we have a situation whereby there's a lot that's unknown for mothers in particular with respect to the epidemic. And hence Messages for Mothers was born. And this next slide is a coalition of several organizations working in the maternal and child health and development field. We've got together, many of the organizations are within the DG Murray stable of organizations. Side by Side is an organization that is affiliated with the National Department of Health. But we decided to group together, next slide, to develop a targeted messaging campaign for mothers with 4 focus areas, one on maternal mental health, one which included mindfulness, and the other on physical health. Our pillar on mothering or parenting at home is still in development, but we're hoping to look at parenting issues as well, which seem to be very intimately related to the other focus areas. Thanks. Next slide. If we look just to highlight the mental health messages that we've developed, these are very short, brief messages designed primarily to be shared on social media. And the 5 key areas that we addressed were stress, depression, anxiety or addictions, family violence, and then an assessment of trying to distinguish between how to escalate seeking help. How does one know one is just stressed versus worrying too much or anxious and needing particular help, and the same with symptoms of depression, when to act. These messages have been designed as brief messages or WhatsApp messages, graphics, which I'll show you in a minute, a mini article aimed at a lay audience, and then these have been also these mini articles have been transcribed into audible podcasts in several languages. We also have posted on our websites, our various websites, other resources, including WHO infographics, etc., pertaining to mental health. And we carefully selected those resources that we thought would be applicable to a low and middle income setting. Next slide. So this is what one of the mental health messages looks like. This is the graphic, which can be shared. It's important to just note at this point that all the resources are open access and can be used, adapted, and shared by whoever finds them useful. So this is what the graphic or the WhatsAppable message looks like, and the image can be easily shared. Next slide. And just to introduce you to the mindfulness podcasts, we had a local mindfulness trainer and practitioner and parenting coach develop 3 brief mindfulness exercises. They're a couple of minutes each that have been designed to be used for a person who may be living in a very overcrowded, stressful home situation. And they are in the process of being translated into various languages. Unfortunately, I don't have time to share with you a clip, but there is the web link over there. Next slide. These are some of the physical health messages that we have designed. Again, these are the messages that we have developed in response to these questions are very brief and developed with the mind that they may be shared via WhatsApp. And the questions themselves have arisen on the whole from mothers in the community who have shared these sorts of concerns that they are having. So these questions have come through the various social media channels of the organizations that are in the coalition. And we have developed these messages in consultation, both the physical and the mental health messages, in consultation with quite a broad of experts and specialists. And there have been several iterations of these messages developed over time and amended with changes in policy and with changes in thinking around response to the virus. Next slide. With respect to the physical health issues for the infant, these are some of the messages that we have developed. There was concerns about breastfeeding, immunization, how to distinguish general flu symptoms from symptoms that could be corona-related, how to protect an infant when there's extended family and a busy household, when people are coming in and out of the house. So we got a group of pediatricians and infectious diseases specialists, neonatologists to help us develop these messages. Next slide. And these are what the physical health messages look like. Again, they're brief, they're WhatsAppable, they're graphics that can be shared. Next. The parenting work that we're doing is in development, and we will be hopefully posting a few interesting and useful bits of information on our websites soon on that. Next. We also did some research on which helplines might be available to cover the need where women and mothers may need to reach out for additional help. And we anticipate that many of the helplines and resources out there are going to be overwhelmed. So we spent quite a bit of time developing a database of helplines and trying to make contact with the senior management and administrators of the organizations behind the helplines to ensure that there was capacity to take up an influx of calls. And that was quite a challenging task, but we felt it was necessary so as not to create expectations that weren't able to be fulfilled by sharing the helpline numbers. We also realized that many of these helplines would be oversubscribed, that people might need to keep trying. So into our messages, we built those provisos in. Machi, if you could just go through the next quite quickly. So you could see there's some general helpline numbers. We specifically sort out some mental health line numbers, violence numbers, and then some helplines pertaining to physical health as well, and social health. Our ultimate aim, and we're working very closely with National Department of Health, is that these messages will be embedded within the NDOH WhatsApp line, and we're waiting for approval for that to happen. So the menu item mothers, will hopefully be added to those, as well as to the mobile platform called Mom Connect, which is a National Department of Health initiative for mothers, where currently 2 million mothers across the country are either receiving SMS or WhatsApp messages throughout their pregnancy and in the months after their birth. And we're hoping that the messages will be embedded in that. So we're working very hard on that process. Next slide. Another programmatic response that we are working with is to work with the National NDOH on a framework and guideline draft for maternal and neonatal care response during this crisis, and for this response to potentially be used in future possible crises that affect maternal and neonatal care. There are several interfaces that, in service provision that have been identified and constitute the architecture of this framework. And we have, a couple of us have been tasked with drafting the policy response to healthcare promotion messaging and communication with the community. And then with each of these interfaces, there are specific tasks and actions that are articulated for each of the different levels of the health system, including the individuals involved in the health system. So that's an early draft document, but that bank of messages that we have developed is an appendix to this draft, which is now sitting with the National Department of Health, specifically the Maternal and Neonatal Care Directorate. Next slide. We are distributing this information as widely as we can on various social media channels, with conventional media, and within a big email push today to over 2,600 organizations in our various networks, in our combined networks. There's going to be a big radio campaign where we hope we will be able to distribute these messages through key influencers and DJs on the radio as well. So we're hoping that we'll be able to leverage these channels, and are strategizing for that to take place right now. Thank you. These are the collaborators from the various organizations and some of the experts that have been behind the development of the messages and the fact checking and the plain language editing. It's been a wonderful team of people. Many of us have not worked together before, and there are lots of lessons that we've learned on how to collaborate across unlikely organizations for a greater good. Thank you very much.
Thank you so much, Simone. It sounds like you and your team have done amazing work in a very short period of time. It's really quite impressive. Thank you. So just to end, we're going to have to pass over to Claire van der Westhuizen, who's going to conclude. And just from my side, I want to say thank you so much for all the amazing speakers and all the valuable information you shared with the rest of us. Thank you.
Joining us soon.
All right, hi everybody. Thank you very much for persevering through this webinar with all our technical issues and connection problems. I'll let you know how you can access the content in a little bit. I just first want to say thank you to Prof. Sorsdahl, Machi Marx, and Amari for organizing this, and to each of the speakers for shedding light on the mental health aspects of COVID-19. I think this was very timely and valuable as we face the upward slant of the COVID-19 curve in Africa. We all know that mental health is not always a priority, and as Prof. Sorsdahl said, it's become impossible to ignore the mental health and well-being of populations at this time. This global threat has brought a number of questions regarding mental health to the forefront, such as how do we support mental health and address mental health symptoms and disorders at a population level. Now, these questions and many others like it, the public mental health field has been wrestling with these questions for many years. But now, when even those with resources cannot easily access care or other activities to support their mental health, the problem actually appears more pressing and demands solutions. And we've had some great ideas about creative thinking from the Perinatal Mental Health Project, and some lovely basic tips from Prof. Chibanda, and also some really great advice on our mental health services and how to look at that as we face the upward slant of the curve. So this is really an extraordinary threat. It's an opportunity to think creatively about our response, and could provide some impetus to incorporate mental health messaging and mental health promotion into all spheres of our society. It's also an opportunity to encourage kindness, compassion, and empathy, and reignite the spirit of Ubuntu and community togetherness. So thank you to everyone for taking part. We will send an email with some responses. I'm really sorry we didn't have time to get to questions. We really wanted to have a great discussion. The recording of this webinar will be available on the Centre for Public Mental Health and Amari YouTube channels, and we'll also post a recording of Prof. Bandawe's presentation. So thank you to everybody, and stay safe and all the best. Goodbye.